Okay, I think we can get started. Good evening and welcome to one of the early sessions of MedChi's AI in Medicine series. I am Padmini Rana Singh, the president of Maryland Medical Society, MedChi. Our goal is to keep you at the forefront of emerging technologies through these programs, empowering you to deliver care that's both safe and cutting edge. MedChi is committed to advancing physician education, leadership, and advocacy. Tonight's session reflects our dedication for ongoing learning, bringing thought leaders, and more importantly, ensuring technology serves as enhance and augment, not to replace your clinical judgment or patient relationships. It's my great honor and privilege to introduce our speaker, Dr. Margaret Lozovatsky. She has a long bio. You can read that online, but she's the vice president of digital health innovation at the American Medical Association. Dr. Lozovatsky is a nationally recognized informatics leader. She guided digital strategy for 15 hospital systems at Novant Health before joining the AMA. Her work spans from EMR optimization, AI-powered clinical tools, and clinician wellness initiatives. Beyond the informatics leadership, Dr. Lozovatsky practices as a pediatric hospitalist. As I serve on AMA Informatics, AI, and Digital Health Task Force, I can attest that she's not only a brilliant clinical informatician, but also exceedingly approachable and dedicated to mentoring trainees and physicians. Today, Dr. Lozovatsky's presentation will cover a few areas. This can be considered as AI in Medicine 101. So you will hear about core principles, terminology, some clinical and administrative applications, and also she's going to touch on ethics, policy, and some future direction. This is a 1-hour CME session, and plan is to have 45-minute talk followed by about 15-minute Q&A. If you could type the questions at the end of the presentation on the chat or during the presentation, it'll be great. Over to you, Dr. Lozovatsky.
Well, thank you so much, and thank you for having me today. I am thrilled to come talk to you about one of my favorite topics, which is clinical technology. We're going to do some basic introductions, as was mentioned, and as far as learning objectives, we're going to define AI. We're going to talk about the history of how these tools came to be, and then we're going to give some examples of where AI is being used today in healthcare. I like to start off with this graphic because it really resonates with me personally as I think about my experience when I take care of patients. This comes from our broad digital health research. When we think about all of the forces that physicians are experiencing today, there's a lot happening that is impacting the way that we practice medicine. And when I think about the role of technology, I hope that we can start to chip away at some of these burdens that we experience regularly in our clinical environments, and the technology can truly become an enabler to help us take care of our patients. And so, as I mentioned, we're going to start off with some terminology and some basics. At the AMA, we like to use the term augmented intelligence, and we think of that as an alternative conceptualization of what AI is. And the reason this is so important is it really highlights the fact that AI is an assistive technology. It is not autonomous. It is used in healthcare to provide information to our clinicians such that they can maintain their clinical judgment. And I really like this terminology. This is something we've adopted at the AMA. We have had a lot of organizations start to pick up on this language because it really makes it clear that these tools aren't there to replace physicians, they're there to augment physicians. A little bit about just the AI landscape. We often, when we talk about AI, particularly in the last few years, we really think about generative AI. So the chat GPTs of this world is what most people focus on. But truly, AI has been around in healthcare for a long time, and we'll talk a little bit more about that. And I think of it as two different categories. There's the techniques things like rule-based systems. So a lot of the clinical decision support that we use today is early AI. Things like machine learning and deep learning and natural language processing, when we can take your note, parse it, and store that information. That is what natural language processing is. And then there's the applications. And one of them is generative AI, the one that we talk about the most these days. But there's also things like computer vision, where we have cameras that are able to capture activities and do predictions. For example, there are camera technologies that are used to predict falls in clinical spaces. There are robotics. So some of you may have experienced MOXIE that has been rolled out in many hospitals. It's the name of one of the robots that does tasks within a hospital. And all of that together sort of encompasses this AI landscape that we often talk about, but sometimes simplified to what Gen AI is. When you think about these other terms, and I wanted to just take a minute to define them because I think sometimes they're used interchangeably. There's the greater augmented intelligence, or AI, and within that, there's machine learning, where we train these algorithms to do certain things. And then when we are training these machines to do more complex algorithms, that is called deep learning. That all is part of what we call AI. And then to break that down even further, there is supervised learning, where these machines learn certain patterns and they begin to predict outcomes. At some point, they have been trained, and so they can predict these outcomes without the supervision. And then there's the reinforcement of these algorithms, meaning that as these machines are making the predictions, they are reinforced based on the outcome of the predictions. And so that is a better, more detailed description of how we think about machine learning. And then there's this emerging concept of agentic AI. And this is something that we've been talking about a little bit more in the last year, I would say, even since the Gen AI phase, where AI became part of our vernacular. And this is a class of AI that focuses on systems that can truly function autonomously. They make decisions, they take actions, and they don't have any human interaction. And so I think largely within the industry, we do not feel that medicine is ready for this concept. And yet at some point, there may be some administrative tasks that allow for agentic AI. It just, we are not quite there yet in the healthcare industry, and yet these tools exist, so it's important to be aware that they are being used in other industries. So thinking about the range of healthcare AI capabilities, there are many different ways to break this down. I like this particular summary because it gives you some of the functions that AI is used for. Some of the more straightforward ones are things like identification. So identifying patterns, for example. This is done a lot in radiology and cardiology, where these tools are able to find incidental findings, for example, in an X-ray. Some of them have been really great at that, and we've seen some improvements in outcomes because these tools are being used. There are translation services. Summarization, that one really excites me because as the amount of data that we have in our clinical records continues to double every few weeks, is what I'm hearing now, we need to figure out a way to be able to meaningfully summarize that information so that clinicians are able to make decisions. And there's a lot of effort being placed into development of the tools in that category. Prediction, there's lots of predictive models out there. Many of you have experienced the rollouts of some of the sepsis models. That was in the early days. There have been many others, deterioration indices. There have been ways to look at length of stay. Lots of those tools are live in our current environments, and some of them are performing very well, and we continue to learn from these predictive models how we can integrate them into the clinical environments. And then there are tools that provide suggestions, recommendations. There's some tools in development that, for example, when you're having a conversation with a patient, they might help you tee up orders or tee up prescriptions, or might suggest a different course of action or suggest a differential diagnosis. But what is consistent across all of these tools is that, again, they're augmentative. There's always a human in the loop in each of these examples. So some considerations when you think about AI, and this is a loaded slide because there's many considerations, and we're all still learning when we're talking about bringing these tools to the clinical environment. Bias is one issue that we talk about a lot. These tools are based on existing data, and we know that our existing data is flawed. Anyone that's ever used an EHR knows that our data is flawed. And so we have to think about how to interpret the results of these outputs and what biases might exist from the inputs. Transparency, that's something we talk a lot about because some of these algorithms are almost like a black box and we don't know what inputs went into them. So how can we possibly interpret the outputs? There's a lot of effort right now in making sure that there's transparency into the inputs that clinicians are able to see. There's a lot of conversation about liability. If an AI tool provides the wrong recommendation, who's liable? Hallucinations. We know that sometimes when you ask a question, it comes up with a very nonsensical answer. Sometimes it's obvious, and other times it's very close, and it can lead to wrong recommendations. Privacy security data right now is widely available in our healthcare environments, but we have to be very mindful of how we protect our patient data, especially because it's necessary to use this data to train these models. And then the regulatory landscape, we're going to go into a little bit more detail into the regulatory landscape and where we are today. There's still a lot of questions of what regulation will look like in the future. So this is a summary of the AMA AI policy. I will not read this to you, but we wanted to include it here just to give you some high-level categories. And it's a lot of what I just talked about. Things that we want to focus on are how do we ensure that liability does not lie with the physicians? How can we ensure that we're protecting patient data? What are the aspects of transparency that we need to continue to advocate for? How do we get the right information to our clinicians in the right way? And you can review them. We'll share the slides, but
8 to 5 is 8 to 9 and 10 and 11, 11 to 12.
I think, oh, there we go. Thank you. Want to talk a little bit about bias specifically and the fact that often we talk about bias when it comes to the data sets that feed these tools, which is the source data piece of it. But really, there's bias embedded into all aspects of the AI lifecycle. So the source data we know can be flawed, but there's also selection bias when we think about model design. And there's bias in how we deploy these tools. Not everyone has access to these tools. There are biases in the way we evaluate them because our current methodology is based on our very biased world. And then how we interpret the results. And I think this is going to be a really important area for us to continue to evaluate to make sure that we address the health equity challenges that come along with what exists in our current environment. And one thing I always point out is that we often want these tools to be perfect. However, we live in a very imperfect world today, right? We know that our human clinicians have biases. We're all flawed. And so the real question is going to be, are these tools with the physician in the loop performing better than the physicians on their own? And if so, how can we continue to improve the data sets that are there and all of these other steps to continue to support the life cycle to get to a better place than we are today with health equity. But I do really like this graphic because it highlights the different areas that are risks for bias and that we need to be aware of the entire life cycle. Oh, I think someone else might be unmuted.
Chang, are you, can you mute? Okay. Now we can't hear you, Margaret.
That's funny. Thank you. You would think we'd get this mute thing by now, but I still struggle. So the AI framework for centering ethics, evidence, and equity is a framework that we've developed at the AMA to really look at all of these different aspects of how we deploy the AI tools, and ethics, of course, being one of them, making sure that we have evidence, clinical evidence for how we utilize these tools. And then, as I mentioned, keeping health equity at the center of all of our evaluation and making sure that we continue to have a critical eye towards health equity as we deploy these tools. So I'm going to talk a little bit about the history of AI, which I think is very interesting because it has certainly changed in my career, and I suspect in everyone else's as well. So here's a timeline of AI in medicine, and you can see it really does go all the way back to the 1950s. And some of these early models were being rolled out in the 1970s. In the 90s, we started to have the pathology expert interpretive reporting systems, which generate pathology reports, and they had very good accuracy. And then in the 2010, we started to use this for patient education. And Cedars-Sinai, where I used to work actually, established the first division of artificial intelligence in medicine. We started to see robotics in the 1960s, and we started to see some of these tools being used in the 1980s for predictive analytics and the Human Genome Project. I think you all remember, and when IBM released Watson was in the early 2000s, and it was really in the 2020s, so in the last, I would say, 5 to 10 years that we started to have FDA-approved AI devices that are now integrated into our clinical care. And so as you can see, the evolution has moved fairly quickly in the last few years. And as I'll show you where the inflection point is with generative AI. And so you can see that this AI backdrop, which existed all of these years, really took off about 2 years ago when we started to see ChatGPT and generative AI. And while it was the uses were rising, and you can see these publication volumes that were increasing significantly even in the last 15 years. It was really in 2023 where we started to see a huge escalation in the rate of change and the rate of technology development. So why is it different this time? We've been using these tools for a very long time. I think there are several reasons. The technology with generative AI is fundamentally different in that it does start to have some features that become more autonomous, and we have to continue to talk about using it as an augmentation tool rather than an autonomous tool. We also are now much more familiar with these technologies in our day-to-day life, and that has been a big difference because we're using them in all of our environments outside of healthcare. And I do think that the rate of change has increased significantly, and so that is also different. There is this burning platform today to recognize the fact that this time it has not been the same as all the other times, and this technology is coming at us. And we have to figure out how to have a physician-led approach in healthcare that allows us to utilize these tools thoughtfully and meaningfully. I want to give you a little bit of an overview of what's happening in industry. And this slide is already becoming a little bit outdated, and it is from less than a year ago. So in 2024, you could see a lot of these companies that were developing the tools fast and furious. And you can see that it's all the big players. You have Oracle that is rolling out their AI assisted new EHR. You have AWS, you have Google, Microsoft. Epic is moving very quickly with the development of these tools. All of these companies recognize that there's a huge opportunity in this market, and so they're all working towards development and implementation of AI. There has been a focus on some of these tools in particular with these companies. I mentioned the Oracle tool, Abridge, I think you're all familiar with, but also Microsoft in the same space, and all of the generative AI tools that they're rolling out and the ambient listening. And so that in the last year has increased in adoption. It has almost doubled, which I have never seen adoption of any clinical technology in my career move that quickly. Elsevier has developed an AI assistant similar to what UpToDate is doing, but they're trying to integrate it into the clinical environment. UpToDate has an AI tool that they're rolling out. So outside of the ambient tools that we're seeing on a daily basis, there's also this movement to collect medical knowledge and bring it to the clinicians in real time to answer questions as we're delivering care. And that is a really interesting space that we don't hear as much about, but all of these companies are in that space. And I mentioned Epic. I would be remiss if I did not cover them because so many of our clinicians are using Epic as their EHR systems. I was at their user group meeting almost a year ago now, so it was in August. And at that time, they had a roadmap of 45 new AI tools that they were developing. There will be another one in August, and I am sure that list will be much, much longer. But I'm hearing from my colleagues that are living in the CMIO spaces that they are piloting tools in just about any clinical area that you can imagine. And so the rate of development is, again, I can't underscore this enough, moving so quickly. And we're seeing on the slide, you can see that the early iteration of this was the ambient listening and some of the coding and billing tools, and then the automated responses to patient messages. There's now a lot of summarization tools, translation tools. There's a lot of prior auth attempts to ease that process. There are many specialty specific tools. There are tools that are looking at the patient experience and interactions with the patients. So all of those AI tools are now being piloted, and I think we're all going to experience them sooner rather than later. This is a little bit of a couple of examples, I would say, of health systems that are incorporating these large language models into their workflows. And these two examples are patient-facing and physician-facing. So the patient-facing one is a chatbot that they're doing at WellSpan that addresses health disparities, and it is trained to interact with patients and make information available to them. And then the physician-facing one is the ambient scribes. And this particular one talks about Deep Scribe. There are so many vendors out there today, and they are being used across the board. I feel like ambient dictation is becoming table stakes in most organizations. And even smaller practices are starting to leverage some of these tools that may be less costly. And the physicians are loving it. I am hearing feedback across the board of how much time it is saving. And I think it's a stepping stone because it is one technology that we're using today. And I anticipate that it will continue to grow and we will have more and more of these technologies embedded. While this is focused on voice, there's already a lot of the computer vision stuff out there. And so there will be video in a future world and many things that we probably haven't yet imagined, which is exciting to think about because we're getting such results with the ambient dictation. And this is an interesting viewpoint that we as clinicians don't always think about, but it is where venture funding is going. And AI is consuming most of the venture funding that's out there today. And it's not just the traditional AI tools, it is wearables, it is tools targeting chronic disease, it is many of the AI technologies that are looking at predictive analytics, precision medicine, all of those things that we've been hearing about that we now have the technology to be able to address. Data is another topic that is being discussed more and more because we are now sitting on so much patient data and there's so much opportunity. So when you think about the evolution from paper to EHRs, what happened in those days is the goal was to digitize the records, and we did that, and it brought with it many other challenges. But what we don't always talk about is that data that we digitized is now a huge asset for all of us because we now have several decades in many instances of patient data. And that allows us to start to build out these AI tools and use that data to train the models to then bring together a full picture of our patient's story and be able to present that back to the clinicians in a meaningful way. And that will hopefully allow us to predict trends, both for individual patients, but also trends for populations that will then be a way for us to think about population health. One interesting tool that Epic in particular has rolled out is they call it the lookalikes, and it allows you to find patients across the country, across the world that may be similar to yours, that may have clinicians that are engaged, that do have clinicians that are engaged, and allows you to contact them to start to learn how they've handled certain cases. And that's an early iteration of this population health vision of instead of contacting individual clinicians, we can start to build a picture of what are the interventions that are most impactful and start to really look at patient outcomes across a large spectrum of cases, particularly for the more rare diseases that we were not able to study in that way in the past. So AI adoption, there's a lot of conversation about where is this going and how do we think about adoption. There are lots of steps that have to happen. We, of course, need developers and investors, and we talked about the fact that a lot of resources are going into that. We need our EHR companies, we need our cloud vendors, we need health systems and employers to really understand how do we take these tools and integrate them thoughtfully into the healthcare environment. This is where we as clinicians are so critical to the conversation in every step of the way, right? We have to make sure that we're partnering with the early developers to help them understand what the needs of the clinicians are. We have to make sure that these tools are being brought to the clinical environment and integrated into our care delivery models. We have to think about how to educate our workforce so that all of the clinicians that are going to be using these tools know how to use them appropriately, understand the outputs that they are receiving. And so while this is so exciting and there's so much potential, it's important to think about all of the steps that need to be taken for us to have successful adoption. And we'll talk a little bit more about that in a little bit. We did a survey of physicians at the AMA, and this has been really interesting for me to look at because we had the same survey a year ago, and then we just did it again in November. So it was end of 2023 and end of 2024. There's a few findings that I thought were worth calling out. One of which is that we went from 38% of physicians using AI tools to 66, which, as I mentioned earlier, is a rate of adoption I have never seen before. So that I think is really fascinating. And we're also seeing that physician enthusiasm is growing. People are more optimistic about the fact that these tools might actually be helpful to us, and they are very interested. There's a few themes that came out of the survey. They're very interested in being engaged. Physicians want to be a part of the conversation. And there's also some conversation and some fear of gaining trust in these tools. I think at the end of the day, we all feel that we want to do what's best for our patients. And that theme of trust came out in many of the questions that we asked, which is the fear that the outputs will not do what's best. And so we want to make sure that we're at the table to implement these tools in a way that will support our patients, support our ability to deliver care. And that's not in the slide. The slide mostly just shows which tools are being utilized most, but I think it's worth calling out because to me, that was a really important learning from this group of physicians. And we really do try to survey folks that are in all care settings, that come from different demographics, that have different areas, both specialty-wise of practice and different geographical areas across the country. So with this rapid evolution, the policy landscape, as I mentioned, is complex. There have been a lot of changes from the Biden administration to the Trump administration, but really what it boils down to is that there are fewer regulations, at least in the early days, what we're seeing in the Trump administration, and more emphasis on adoption. And so in the first 3 months of 25, there were over 250 AI bills, and that would impact, of course, all of us significantly. 42 states have introduced some legislation, and there have been 6 bills that have been signed. The legislation is moving, and yet again, the focus is on adoption right now and less focus on legislation. And that was another thing that came out of the physician survey, is there is a lot of desire to make sure that we do have some regulation that allows for adoption of these tools in a way that will protect the clinicians and protect the patients. So medical societies are also releasing principles. We talked about the AMA principles. This shows the double AFP and the ATA principles. Today, actually, earlier in the day, we convened 30 plus specialty societies here at the AMA, where we brought them all together to talk about what each of them is doing so that we can continue to understand the greater landscape of the needs of each specialty and what is similar and where they're unique. And so you can see from this example is that there's a lot of converging principles, right? We want to continue to keep the patient-physician relationship at the center of the conversation. We want to mitigate bias. We want to maximize trust. We want transparency. I think that is a theme across the board. We want to make sure that patient data is protected. There's a lot of focus on interoperability so that we can actually see records from other systems, which no matter how much we worked on it, we still struggle with. And what we're hoping to do with those groups is to come out with some model cards that are very focused on the clinical applications of these tools. So that's what we worked on today. More to come on that. But wanted to share that because there is now work being done in this space across our industry, and we at the AMA really are working to keep that all together and have a strong physician unified voice. So we talked about some of the industry groups. I mentioned the AI Specialty Collaborative, but there are large groups such as CHI that are also working in this space. They're more focused on the technical specifications. AI Med is a group that was started a few years ago that is really focused on the physician experience with AI. It's run by Anthony Chang out of San Diego. And then there's a few collaboratives that are pulling people together, such as Valid AI and Health AI Partnership. There's many others, that's to mention a few. There's lots of groups working in this space, and at the AMA, we really are working on staying aware of what's happening and pulling people together so that we can continue again to advocate on behalf of physicians.
Is this the end of it?
Oh, I think someone came off mute again. So the AI landscape, current applications and use cases. Want to give a few examples, some practical real life uses, but also more of the landscape of the industry. This is an interesting slide, and I don't know whether this is what will happen, but I think it's a great way to look at it, is how do we think about these tools that are lower risk and low effort to implement versus higher risk and maybe extensive effort to implement, and where in this graphic do we want to move? There's a lot of this that is already being used today. So we know, for example, the generation of clinical notes, as we talked about, is widely adopted. And then there are things like fully autonomous robotic surgery that are probably closer to science fiction, and everything in between. But it's an interesting way to consider where the industry is today and where we're moving. This is something that we pulled together actually from the AI Specialty Collaborative. And these are some use cases that each of the specialties is reporting. Again, I won't read it to you, but I wanted to include this because it might be particularly interesting to you to look at your specialty and what are some of the things that the specialty societies are seeing and hearing and where these tools are being utilized. There's also a lot of non-clinical uses. We talk a lot at the AMA about the fact that this is sort of the lowest risk area to start with. And so there's a lot of effort being put into utilizing these tools to increase access, to think about the rev cycle, for example, where there's so much that's ripe for automation, looking at these tools for patient education and research. And because these are truly non-clinical in many situations, the risks can be lower and is an area that we really want to focus on, this decreasing of administrative burden. It came up as the top area that physicians from the survey would like to see us focus on. So what's being used most today from the survey? What we're seeing is that, again, documentation, billing, and medical charts is the number one thing that our physicians mentioned. The creation of notes, different kinds of notes, translation services, those are some of the top utilizations. What you don't see as much of is diagnostics and therapeutics. That is technology that we are thinking about and we know is coming, but is not where we are today. We're really focused on some of the slower hanging fruit with the understanding that these technologies will continue to evolve. I did want to touch on AI in radiology because it has been used in radiology for a long time. They have always been early adopters and have been incredibly successful in utilizing these tools and assessing outcomes. And so a couple of common use cases are things like triaging of which images have critical findings, image analysis, so the incidental findings that I mentioned earlier, quantification of particular measurements, decision workflow support, so helping to make sure that the right images get to the right people in the right place. There's a lot that is being done in neurological studies where we can start to diagnose things like stroke earlier, and we can decrease time to treatment, which has been really interesting and very successful. And of course, diabetic retinopathy is an area where we had our first autonomous device that was passed to be able to diagnose that, and that happened in the last year and was a very exciting development because we have so much trouble with getting access to those patients, and hopefully this will allow them to get care earlier. Ambient documentation, we talked about a little bit. What I did want to bring up about it that we haven't talked about that is interesting and I think will allow us to look at some of these tools with a bit more of a critical eye. As I mentioned, across the board, people love it. There are a few outliers. They are not the majority. Sometimes we hear from clinicians that they don't. But the part that I think is really interesting is that we're not necessarily seeing objective data to show that people are actually spending less time documenting or less time in the EHR. We're seeing that people are loving it. We're seeing that their experience is better. There is a perceived reduction in burden. And we're still analyzing how does this relate to our analysis of burnout. A few theories out there is that it decreases cognitive load and it allows physicians to actually take a time to think about what they want to do. And perhaps they're spending time in other parts of the chart. But total time in charts in many studies, not in all of them, but in a large majority, has stayed the same. And so I think this is an interesting finding because as we look at how we evaluate these tools, we have to keep in mind that perception is important. The fact that people are feeling better is important. And we don't always measure that. And so this has given many of us, especially those of us that think about well-being and how to quantify it, a lot to consider as we move on to the next iteration of some of these AI tools. AI and bots, just wanted to talk a little bit about that because there's a lot of utilization for these bots, and particularly when we think about our challenges with capacity. Is this an opportunity for us to thoughtfully to increase our capacity and get access to people that may not have access, with making sure that we have clinicians in the loop so that the guidance people are getting is appropriate. And this is just an example of utilization of a bot that allows us to use open evidence, perhaps, to collect the data that we need, something that's ripe for automation, submit that data. And one of the best examples is the prior auth process. But there's many other areas where we can continue to utilize these bots. The concern, of course, is then you start having bots talking to other bots. And so we do have to think about, again, how do we thoughtfully integrate these tools, take out the administrative burdens, and leave the clinicians where they need to be, which is making the clinical decisions. Another example is the automated in-basket responses. And what you see on the screen is actually a framework that we developed at the AMA a long time ago when we were looking at in-basket, which tends to be the number one thing that we hear from our ambulatory colleagues. And it was to eliminate, automate, delegate, and collaborate as sort of the 4 different areas that we thought about. And then these AI tools came to be, which compose the message for us. And so they do function in both automating and providing team-based care. And again, we're learning, because this is so new, what seemed really great in theory, which is these automated response technology tools. We're seeing that often it takes longer for clinicians to edit the notes rather than write it themselves. And so they're not being well adopted in every environment. And what we're finding, which I find fascinating, is that many of the non-physicians love it. And that's where a lot of the utilization is. And again, these are early days. We're learning. I think what's important is to understand that we thought this art technology would be perfect for these eliminate, automate, delegate steps. And yet we're not finding that in many clinical scenarios. And so we'll continue to think about what is the right way to help to automate and eliminate some of this work. And how do we get ahead of in-basket messages, perhaps, when we think about providing education, and can AI be used for that so that we don't get as many questions? So there's a lot of those conversations happening right now as we're still learning. AI and predictive analytics. So I won't go into all of the examples, but predictive analytics is being widely used both in clinical and non-clinical spaces. So things like hospital staffing volumes in the non-clinical spaces, looking at ways to actually staff across various specialties, various locations. And then, of course, in the inpatient spaces, really getting into predicting deterioration, predicting outcomes so that we can get ahead of them. And some use cases with AI in education. There's a lot of work that the AMA has done in this space where we really think about what we call precision education, where our learners get the right information at the right time. And so lots of these AI tools, we are talking about how to integrate into all levels of education, from undergraduate medical education to graduate medical education. Looks different on the wards than it does with book learning, but different ways that we can continue to assess our learners and meet their needs where they are. And finally, I want to run through a couple of pearls of ways to think about these AI tools as we continue to move at lightning speed. It's going to be important for us to understand what the capabilities of AI are versus the capabilities of humans. And I like to say that computers should do what they do best, and we should do what we do best. And what we do best is we have imagination and we have abstract thinking and we're creative beings and we have clinical judgment. That's why we went to medical school. Computers are really good at pattern recognition, analyzing images, processing huge amounts of data, and truly translating them into information that then is presented to the abstract thinkers that are able to make decisions. And I think that these distinctions are important for us to remember so that we can critically assess where these tools can provide value and how can they be augmentative to our ability to practice medicine. We need to continue to be aware of what we know and what we don't know. The few examples I shared about things that we assumed of these AI tools and what we're finding are already demonstrative of the fact that we're just scratching the surface of what we know, and we need to continue to assess these tools as we bring them into the clinical spaces. And we talked about all of these risks, right? Cybersecurity and the fear of liability and all of the different areas that we need to continue to assess with a critical eye. This will become more and more important, and it'll be really critical to have places in your organizations and your practices that are focused on that work and that continue to monitor these tools, because the worst thing we can do is put them out into the clinical spaces and not have a way to continue to assess their efficacy and all of the potential risks that come with that. So clinical information is critical. Clinical informatics is critical. And I don't want to belabor this point, but I do want to highlight the fact that we now have folks that are specifically trained in this field of clinical informatics that understand the nuances of what it takes to bring technology to the clinical environments. They're mostly physicians and nurses and people that have been clinicians and continue to be clinicians. I have continued to practice through all of my clinical informatics work. And so we want to make sure that we continue to include our colleagues who have this training in all of this work, because it's really important for us to be very thoughtful as we think about the fact that these tools are going to largely drive the way that we deliver care. It's important to have a strong governance model, and I won't go into all of the details, but I will share that we just put out through the AMA an AI governance toolkit, and we did a webinar where I reviewed the different aspects of it. But essentially, it's the building blocks of what one needs to be successful as they embark on this journey of implementing AI tools. And it's important to have an intake process, to have a transparent approach to all of this, to have a multidisciplinary approach, because we know medicine. We need our IT colleagues, we need our administrative leaders, we need our operational leaders to partner together so that when this governance model exists, it allows for quick ability to assess the tools and for implementation in a way where we truly are supporting the clinicians. And finally, I'll end with this thoughts. I know we all like to do things the way that we like them. And I can't tell you how many times, and I've done a lot of change management over the years, how many times I've come to my physician colleagues with what we thought was a great idea, and the answer was, that's not how we do things. We just retired our pager in my clinical group about 2 months ago, so that just tells you how tied people are to processes that they've had for years, and we're finally not writing down admissions on paper, which I thought was a very big win for me. But these tools, they're coming at us. They have a lot of potential. There's a lot of good that they can do, and it's going to take a lot of effort to be able to get them across the finish line, get them to the point where we do get the support and the buy-in from our colleagues, and we have to be thoughtful in the way that we do it so that we don't create additional risks. And as you can see, we're all busy. I know we're busy, but this is really important work. And so with that, I will pause, and hopefully we'll still have a few more minutes for questions.
Thank you so much, Dr. Lozovatsky. It's really a not only a great summary at a higher level, it also comprehensive. You touch on most areas that we feel like really important. And I know we have few questions. I'm going to read them to you on the chat. Is there a complexity level that makes the dividing line between machine learning and deep learning?
Oh, that's a good question. I don't know if there is a true definition that exists. The way I think about it is if there is a multi-step process, I think about that as more of a deep learning. And in healthcare, I think most things are deep learning.
And the next one from Dave too. Aren't there still example of medicine choosing algorithms that introduce bias? Example, pigment and oximeter or race-specific adjustment of reference lab values.
That's a great example. Our pulse oximetry data is another really good example. Trying to think.
I think the kidney function is the next one, right? Like the
GFR. Yeah,
Yeah.
that when you say race-based algorithms, that's the one I think about is that when we had race-based GFRs.
And then another question is you mentioned about the collaborative, like the group that the AMA convene, nothing on psychiatry.
We had a person from psychiatry, Dr. Darlene King. She's fantastic.
And I'll go to the next one later. And one of the other ones, thanks for the summary. How do you think adoption of AI will affect malpractice, both from claims and the defense perspective?
Oh, that is a tough question. I think that we don't know what we don't know. And so I don't know whether there will be an early phase that will create some litigious behaviors. What I think will happen long term is that we will get to a place where the question will not be whether the AI algorithm is correct. The question will be, why didn't you use the AI tool? Because we're starting to see that already in areas like radiology with incidental findings, where we know that those things would have been caught because we can compare them to other areas. And so I think the more data we have, the more imperative it will be to use these tools because the risk will be higher to not have them embedded. I did think of another great example of bias in my world of pediatrics, growth charts. They are created from white babies. And that is not how many racist cultures, that is not the rate of growth that they have. And particularly, we know that South Asian babies do not fit on those growth charts. And so we do have a lot of examples of that. Many of our algorithmic approaches, hyperbilirubinemia is another one that was measured mostly on white babies.
And the BMI too, then, right? I mean, so many of them. And one other question is, there are independent medical examination companies that are sending letters saying we can't use AI. Your thoughts?
I need to learn more about that. Tell me more about these letters.
Dr. Pushkin, over to you.
I'm unmuting myself. Just that. They are saying do you know what an IME is? It's an evaluation that's done for the legal process or for an insurance company. Is more treatment needed? Is a person can go back to work, that sort of stuff. And they're just sending out letters saying we cannot use AI in any part of this process. So it's interesting if they're being treated and using AI algorithms, what have you, in their treatment, where do you see all of this coming in?
I understood it that you can't use AI in your response.
Right, but yeah, if everybody else is using AI, just how would this play a role?
Yeah, that's a great question and probably another area of advocacy for us as physicians because we know payers are using AI tools. We know that they're probably using AI tools themselves. And so putting that administrative burden on the clinicians does not make any sense. This is the first time I heard about it. If you have anyone, I'd be interested in learning more, and we'd be happy to bring that back to our advocacy.
I'll check you after.
Please, that's definitely a very fair question we should think about.
I'm going to give floor and very succinctly a bunch of things he's asking to say. That will be the last one. Like
Not generous. So I worry about the organization. My understanding is that at a general, the smaller practices are more interested in younger patients. The larger practices are at their best interested in making access available and making the necessary, making the expensive papers and advantages that connect you. As somebody who is, I would say, psychiatry adjacent, work deeply with psychiatric specialists, transfer patients exactly what you need, show the patient's thought process. Other times it is just waste time. And I don't know that AI yet knows this. I don't see any reviewing organization trying to pick an EHR. There is no consumer reports for EHRs, and it's a scary landscape with these companies having motivation and future and control. So those are the 3 points I think are worth making on the big one. I got a little mic one. Thanks.
Thank you. Thank you for the comments. I will say, that does clinical technologies and plus KLAS. I'm actually giving a note there this week. So I'll put a plug for publication. I have no action other than I've used myself in my CHIO. But I think it's hard to motivation. What I say is there are many look at quality care, right? There are in the bodies that fall across the board, and because we analyze those quality measures that are applicable across all practice sizes, and it'll be important for us to continue to have a critical eye as we roll towards how they impact patients and patient outcomes, because ultimately that is the goal.
Okay. Thank you all for your attention and participation. So big round of applause to Dr. Lozovatsky. And finally, I say to claim your CME, you'll get an email, just fill out that form and back to MedChi. And then we invite you to stay engaged with MedChi, even if you are from another state like Dave and Colette, right? Share your feedback, suggested future topics, and join our AI working group. I think together we'll continue to advance physician education across Maryland and US. And finally, I would say great evening, and I look forward to seeing you at our next session. Thank you so much.
Thanks.
Thank you.